Yes, we do.
Great. So we will talk about. I don't see you right now, so you have to raise your voice if you have any question. I don't see if Anna is joining me, and I hope she will just interrupt me if she figure this sound thing out. We will talk about people with intellectual disability in Sweden, and we will talk about 3 projects actually. One project that's finished, that started in 2014-15 there, and that ended in 2019 or perhaps 2020. I don't really remember. And we will talk also about 2 other projects that we have received funding for in the last couple of years, and that we are starting up right now. It's been a little bit of delay because of the pandemic, but we are getting a lot of data right now. We got a confirmation from one of the registries today that we got the data, so we are very excited about that, but we'll talk about that in the end of this presentation. So I'm not sure about how much you know about Sweden, but Sweden is located in the northern part of Europe. We have about 10 million inhabitants, so it's not too big country when it comes to inhabitants, but geographically the area is a quite large country. We have a few big cities in Swedish terms. So Stockholm is probably one that you know about, with roughly 1.5 million inhabitants. So still in a world comparison, that's a quite small city. Lund is located in the southern part of Sweden, and we will see that in a slide further on. And the need for all these projects that we will talk about is from the perspective from the practice of disability service. There's a lot of questions, and you're probably aware of this already, but I'll take these slides anyway, about what happens when people with the intellectual disability, when they get older, in what way do they age, and are they aging in the same way as the general population? That was actually one of the main questions that we had from the beginning. And the managers from the disability services, they also raised the questions how they best could support the staff and how to manage the everyday care for this group. I mean, I don't remember the reference, but I know there's numbers that people with Down syndrome has increased the life expectancy with 30 years the last 30 years. So this has been a dramatically increase in people with intellectual disabilities. And the leaders also expressed that they wanted help from the researchers from the university to understand this and how to better run the everyday care for this group. And as I said, the scientific rationale was about the life expectancy. I mean, it's true both for the general population and for the people with intellectual disabilities. And when you look at the literature, there weren't really that much. It was usually small studies with a specific group of people with intellectual disabilities, as Down syndrome, for example. They were often cross-sectional. They were including all ages or low ages, and rarely there were any group, control group or group that they compared to. So we were looking for making a more comprehensive project and to investigate more than one outcome to get a broader perspective. And I'm sure you know about the different the definitions of intellectual disability, and I just put the one that we used in this slide. Another definition that's important that we used a lot is coming from the Swedish Act concerning support and service for people with certain functional impairments is called the LSS. It's an abbreviation in Swedish, but this law describes what kind of services this group is entitled to. And in Sweden, we are much into to have these kind of registers and to register people in different ways. And if you are entitled to services according to this law, there are information in the register about what kind of personal circle or what kind of disorder you suffer from, if it's a disorder from birth, or if you got it later on in your life, and so on. And there is, the first one is with for people with developmental disorders, autism or autism-like disorders. And according to this LSS law, you could get different kind of services. I'm sure you're aware of that the Sweden has a lot of a social democratic tradition. So we have a quite strong safety net for people, and people without actually too great expenses could get this kind of services from the government or from the county council or the municipalities. And you can get counseling and other personal support. You can get personal assistance, companion service, contact service, relief service, short stay away from home, and daily activities, and so forth. We use this kind of information to see or to define those in people with intellectual disabilities. So as long as you have one of those services, you will end up in a register, in a national register. We looked at the different acts that actually relates to this group when we talk about older people with intellectual disabilities. It's both the LSS Act, as I spoke about, but also we have a Social Service Act, which is for people 65 years and older in general. And we have, of course, a Health and Medical Service Act that relates to hospitals and that kind of the care that primary care centers and hospitals give to people at all ages and are provided by the county councils. We had a little bit of struggle to get an ethical approval from the ethical review board because they didn't really like that we investigated this group that is quite frail. So they wanted us to have ads in national newspapers with information how to withdraw. We had an anonymous data set, but still they wanted us to do this. So people couldn't contact us if they wanted to withdraw from the study. They had to contact Statistics Sweden or Swedish National Board of Health and Welfare, because there were those that provided us with the data. And we had to analyze on computers without internet access, and it was a lot of quite strange decisions from the review board. I think they've changed a lot about that in the last years, but back in 2014-15, it was quite a big issue. I would also say a little bit about the validity of the registers, and this is about the national registers in general, and also more local registers. We have poor validity for some of the registers, especially that the register that's connected to the Social Services Act. And there are some information that's lacking in some registers when it comes to national patient data. We don't have information about primary care on a national level. But otherwise, the registers have a quite high validity, or very high, because they are all connected to a reimbursement system. So without registrations in the registers, you don't get any funding from the government or from the county council. So there's actually a very good coverage on the systems. Not all registers are suitable or made for research purposes. Some of them are made for more administrative reasons. So it's been a little bit tricky to use them in research, but I think we managed it quite good. I will also want to say something about linking up to data. We had a pre-meeting. I don't remember if it was in September in NASA, but when we talked about just briefly about the studies, and one thing that occurred to us was that we have a quite unique way to link the data between the registers and different individuals. People in Sweden, when they are born, they are given a personal identity number, or if you come from another country and you settle in Sweden, you will get a personal identity number as well as an identifier. And the number is based on the date of birth and additional 4 numbers. And you will have this number throughout your life, and all people know about the numbers, and they are used for communication, especially between governments and authorities, but also in private companies and other organizations, and also by citizens. I could, for instance, contact my hospital to get information about what they have written about me based on my personal identity number. Or I could contact Lund University and ask, in what research project do you have information about me? And this is my personal identity number. Please look that up, and I will get information about that as well. So it's widely used, and when you have an account at a local store and they want to put you in a register, they will use this number as well. And in this way, we could use, because it's the same number in all registers. So if you are in the LSS register, for instance, you will have your personal identity number there, and you will find the same personal identity number in all other registers as well. So what we did was we used the LSS register to identify a cohort that was alive in 2012, in the end of 2012, that had LSS support according to this LSS law that was 55 years and older, and that belonged to this group of people with intellectual disabilities that I described earlier on. In Sweden, as I said, we're not a very big country, but almost 8,000 individuals in this cohort. And based on this cohort, we published a prevalence study that used the LSS data. And I will be happy to send you the presentation to you further on. And you will get all the references to all our publications. So this was the first publication, I think, in the project, and the last author, Jed Ahlström, was the PI of this project, and I think she's author or co-author in all publications. So this study looked at the prevalence, and what we could see was that the prevalence increased slightly over the year, and that made us draw the conclusion about that the age, the life expectancy still increased in this group. We could also see that men had a slightly higher prevalence of intellectual disability, but that the gap between the gender decreased with age, and of course the prevalence decreased with age, and that I mean, that's really logical. We will also look at, this is a little bit a strange map and a way of dividing Sweden, but this is the three main regions in Sweden. The picture on the far left is the northern part of Sweden, and on next to it on top is the middle part, and the one that says Götaland in Swedish is the southern part. And what these pictures mean is the one with the red areas is on the left side is I don't know if I could use any kind of pointing tool, but anyhow, the dark red is municipalities with high prevalence. I think it was, if I remember correctly, I think it's 28 municipalities with a prevalence of above 500 per 100,000 inhabitants. And half of them were located in the northern part of Sweden, especially in the northern inland. When you look at the pictures on the right, you will see that there are also red areas, and that are those are areas of municipalities with high prevalence that's surrounded by other municipalities with high prevalence. The yellow one is those that's surrounded by low prevalence, high prevalence, but surrounded with low, if I remember correctly. I just want to make sure that those with green, those are green, those are the high with low municipalities surrounding. The yellow one is area with I don't really remember. I think the green one is the one with high prevalence surrounded by low, and the blue one is low, and the yellow one is low high. So the yellow one is low prevalence surrounded by high. Sorry, I'm a little bit confused here, but it was a while since we looked into this. Conclusions of this study was that, as I said, the prevalence increased, higher among men, but the gap decreased slightly. And that the prevalence was higher in the northern counties or municipalities, especially in the inland. We draw the conclusions that was probably a lot about moving around, that people in the northern part, the communications are not that great in northern Sweden, so it's perhaps a little bit more difficult to move, while in southern part of Sweden it's much easier to move around and to move from your place of birth to another major city. Yeah. We also use the total population register, and that's a register that comes from Statistics Sweden, and that's an excerpt from the tax register. So we could identify all people in Sweden in that register, and we could have a look at as I said, personal identification number, age, sex. You can get information about residence, civil status, and etc. We used age and sex to make a general population cohort that was matched by sex and year of birth. So we had an equally large cohort group that we wanted to use as a reference. And then we used the National Patient Register, an additional register, to look at inpatient care and outpatient special clinic care. we had a lot of data about patient data when it comes to diagnosis and where they were admitted from and where they discharged to and so forth. There's also a little bit of geographical data and administrative data in that register as well. And we use that to combine both cohorts and to look at different things using the National Patient Register. So we had publication about somatic diagnosis, somatic healthcare, psychiatric diagnosis, psychiatric healthcare, falls, geographical variations. I think this list of publications are quite up to date. Probably some of the submitted papers are published by now. I'm not really sure. I'm not going to go through all of them. I will give you one example when we looked at somatic healthcare utilization patterns. And this is one of the main results. We looked on the left-hand side of the screen. You will see the intellectual disability cohort compared with the general population cohort for the different age groups. And what we could really see here was that there was a decrease with age when we compare the groups and the cohorts, especially when it comes to planned care. And you could see that for unplanned care, the intellectual disability group had a odds ratio above 1, which means that they have more healthcare utilization than the general population. But when it comes to older ages, and especially when it comes to planned care, we could see that the confidence intervals are below 1, which means that they get less planned inpatient and outpatient care. When we looked at the age group within the intellectual disability cohort, we could see that there was a quite steady increase about unplanned inpatient registrations. We could see that a little bit when it comes to the outpatient visits, but it was really a really high increase when it comes to unplanned care. Oh, I've forgotten that I enlarged these figures as well. And this is basically what I just was saying. And it was really interesting that we could see this quite clear pattern when it comes to the planned care, and we know that this group is have had this condition from early age. So the planned care would logical. It would be higher because they are known by the physicians. They are known by the hospitals and so forth, and we know they have certain issues that need to be dealt with. We actually have another publication that's not been published yet, where we adjust, we do regressions where we adjust healthcare utilization for diagnosis, age, and sex, I think. And we could still see the same pattern, that they are still in risk for greater less amount of planned care and higher amount of unplanned care. We also have a register, of course, about prescribed drugs in Sweden. So if you have a prescription from your physician, that will be in a certain register, and although it will end up in the register when you dispense the drugs. and that was available from 2005 and forward. And it's about 84% of all the drug sales in Sweden. We have some drugs that you could buy without prescription, but all of the more heavy drugs or more complex drugs are on prescription. And we use that register to do additional studies, and we combine the prescribed drug register with the patient national patient register as well. That's why the boxes are light blue in this case. I'll just give you a brief example of this. We looked at potentially inappropriate medications among these groups. And what we could see that the people with intellectual disabilities had much more prescribed of potential inappropriate drugs than compared to the general population. And that was true for all, but for painkillers, if you look at NSAIDs and tramadol, you will see that the people with intellectual disability is below the dotted line, which means that with the risk ratio is lower for the people with intellectual disabilities. So people with intellectual disabilities were more likely than the general population to be prescribed medication with potentially inappropriate medications at least once during the study period, and also had more number of years with prescription. And that was true for all except for benzos. And as I said, different patterns were seen for painkillers. And that could perhaps be related to communications difficulties between people with intellectual disabilities and physicians or people that care for them, that they have difficulties to communicate their pain and where they have pain and what kind of pain and so forth. Yeah. We also used the National Patient Registry to look at different sub-cohorts. We looked at people with depressions, tried to identify those with Down syndrome, autism, and dementia. And we looked at people with dementia and their healthcare utilization and also prescribed drugs. And I wasn't really a co-author. I wasn't a co-author of this paper, so I have a little bit difficulties of describing this. But I don't know if Anna is along us. Are you here, Anna? No.
She's speaking, but we can't hear her.
Can you hear me now?
Oh
Yeah.
yeah.
Okay, you can hear me?
Yeah.
Yep.
Could you hear us?
Okay, lovely. I'm doing multiple things here. So I'm in the meeting on my phone and on the computer, and I'm hoping that the charge will be enough for me to finish the meeting. Yes. So
You're warmly welcome, Anna. I'm really happy that you could join us eventually. Could you just could you just introduce yourself just briefly?
Yes, I can. My name is Anna Axmon. I'm a statistician and epidemiologist, and I did a lot of the data management and statistical analysis and writing on the project that Magnus is talking about now, or has been talking about for a while. And I'm really sorry for all the technical difficulties here. I'm hoping I can stay with you for a while longer now. And talk about the dementia. As Magnus said, we looked at. Okay, now I'm hearing myself. We looked at the subgroup of people with dementia. So we had people with intellectual disability and dementia, and then the general population and dementia. And we compared 4 different types of medications in these groups, and we found significant differences between the general population and the people with intellectual disability. So as you can see, among people in the general population, the most common medication they got was the one that I have problems pronouncing, anticholinesterase, whereas among those with intellectual disability, they were primarily given antipsychotics. And if you could go to the next slide for me, Magnus.
Yeah.
Yeah. So there we have it's the odds ratios for the entire study period, and we see that people with intellectual disability are more likely than people in the general population to be prescribed antipsychotics. People with dementia are more likely than people without dementia to be prescribed antipsychotics, and people with intellectual disability and dementia have an especially high risk to be prescribed antipsychotics. And sort of the conclusion here was maybe we should do an overview of that. Because there are so many side effects with antipsychotics, that's especially bad for people with intellectual disability and people with dementia, and with the combination, it's not good. Are there any more slides from it? No? Okay.
No. So that's what's really what was planning to say about the previous project. I mean, we could talk about the different publications for hours. I mean, I think we have like 30 publications or something like that. So there's a lot of data and a lot of results. So this was just a brief insight in the different kind of publications.
And if I could just jump in there, Magnus, to
sure.
say that all the publications are open access.
Yeah,
so
good.
You
good
can
point.
go ahead and read them. Yeah.
Yeah, and I think I have the reference list on the end, or otherwise you will have it in the presentation that I will send you. So I thought that we now would spend, I don't know about the time, I don't have a clock in front of me, and I can't.
So, Magnus, if you can wrap up in like 5 minutes.
Yeah, great. That will suit us perfectly. So this is the 2 new projects that I talked about, and we initially got funding for the first one. We wanted to look at this group compared to the general population, but we wanted to look at all ages. We wanted to include primary healthcare data, and not only survivors that we had in the previous project. So we got funded for the first one, and during the COVID there was another call for funding, and we did another application that was successful. So we got that response in October, I think, Anna. Yeah, doesn't really matter. So we've been applying for data for COVID data as well, and those are based on the same cohort. So we'll combine these studies into one more or less. And this project will take place only in Skåne or Scania, which is the southern part of Sweden, where we live. And the largest city in this area is Malmö. It's located quite close to Lund, and it's 300,000 inhabitants, and is actually Sweden's third largest city. Do you want to add anything, Anna? No.
No, I think you did it very well.
Yeah, great. So what we will do is to identify the population living in this region in 2014, the 1st of January, where we'll then add a lot of registers to this population. we will use, in the same way that we did in the previous project, we will use the LSS register or LSS support register to define the group together with diagnosis in the healthcare registers to get a cohort, and then we'll try to link different registers to this population. So we'll have people with intellectual disabilities. I don't know if we have any approximation about the number of people with intellectual disabilities, but
we have just based on because we haven't got the data from the National Board of Health and Welfare yet, so we don't know additional people that will come in with LSS support. But using the diagnosis from healthcare data, I think we have about 8,000 with intellectual disability of all ages.
Yeah.
Yep.
And the general population is about 1 million people, roughly.
Yeah, 1.2, I think. 1.2.
1.2. Okay.
Yeah,
yeah. So it's going to be a quite large study, and we just received some of the data. And correct me if I'm wrong, Anna, but it was like 100 million. Care registrations.
102 million healthcare visits, actually, and that's not including 2021. So we'll get a bit more.
So that means that we will have. I mean, we're struggling to deal with this really huge data set right now, and how to deal with that. And university is a bit concerned as well, because when Anna starts analyzing, the system is lagging.
I'm crashing the servers here at Lund University.
Yeah, but this is really unique for not only Sweden but throughout the world, I think. So this are some of the references. I don't know if there are exactly all of them. It could be that some are missing, but I will try to look that up. Yeah, I think we stop there and open up a question. Yeah.
Yes,
thank you.
So yeah, thank you so much, Magnus and Anna. And I'm always fascinated by your work, because the registers just don't, in the US, it just doesn't work the same way. So any questions?
Gold mine.
So, okay, any questions? Yeah, I guess you have a lot of questions, but yeah.
So I'll just quick say I have a comment. I served on a human rights committee in Western Tennessee a number of years ago, focusing on adults with intellectual disabilities living in the community, having moved from an institutional setting years before. One of the things we found was exactly what you're talking about in terms of antipsychotics being really heavily prescribed, to the point that they were, as we looked at individual people, the individuals, we could see that sometimes medical problems were underlying behavior. There were other problems that were there that were being treated, that were being overlooked. And it reminds me of the diagnostic overshadowing term that we used to use. It's like we would see behaviors and say, hey, we got to treat this behavior here, totally disregarding constipation, basic stuff that people deal with in their lives. So
yeah, we actually, there is one publication that we did looking at those with a prescription of antipsychotics. And if I remember correctly, the higher sort of risk factor to be prescribed was behavior impairment. So it's like they're troublesome, so we will sedate them. Yeah.
It's really interesting to look at those living at the institution, and because I mean, there is a sense of a certain thing. I mean, we've been talking a lot about dementia, and that was one of the reasons for looking at that subgroup. But we couldn't really see that the prevalence of dementia in our cohort was that high that we thought that it would be. So there's a lot of things that we think is true about this group that we couldn't prove. So it will be very interesting to look at that too when we get this more comprehensive data set.
Yeah, especially as now it's not just the survivors, but now we have, I mean,
yeah,
so we had sort of a healthy person selection in the previous study, which we won't have in the next one.
Yeah, I think most of the result might be true anyway, but we could be more confident in our conclusions in our upcoming study.
Yeah.
There is this is Sarah Ailey, a subgroup of the grant, actually they're pharmacists, but are looking at issues of polypharmacy. And, I think we could look at, is there a way with our IPE program to look even at that issue? Are we able to get, for people we may interact with or agencies, is there a way to look at whether we get use of meds, quote unquote, down? I mean, that's a rough measure you want, but even if like doses or what, there's huge amounts of polypharmacy is a huge issue in this population. I'm jealous of the data you can access. Tricia might want to say something about that. It's very difficult to get this kind of population data. Yeah. I don't know, Tricia, did you want to comment on that one?
Especially unless, can you hear me now? Yeah. To get that level of population data, we almost need to rely on Medicaid, to the extent to which Medicaid or Medicare claims are available, because otherwise getting data from individual private insurance companies would be, I don't want to say anything is impossible, but it would be much more effort than probably we would garner from the benefit. But to the extent to which Medicaid and or Medicaid claims data could be used, that's definitely possible.
So, and I should mention that Tricia is a co-I on the grant, and particularly she's a healthcare economist. So particularly to look at, are there economic or these kinds of implications to the work that we're doing. So
maybe we should mention that as well, Anna, that we also will look at costs. Hopefully, we have a health economist connected to this project as well. So we will get cost from the healthcare registers, I think. So we'll be able to compare the intellectual disability cohort to the general population as well. So.
And then, of course, we're talking about costs for the sort of region or county, because I mean, healthcare in Sweden doesn't really look like healthcare in.
Yeah.
So the individuals here don't carry that high cost for healthcare, but it's society that does. So, yeah.
I'm certainly we'll probably want. There's another grant, I think it's funded by Nadler, but where there's a whole part of it that they're trying to do something about the fact that access to any kind of data is so poor, and how to improve that. I'm sure they'd be interested in all this. We can contact them, or if we maybe send them the slides, they may also like to be talking to you.
Questions?
A request for CDC for data linking project specific to IDD, and there already are about 10 states where they're putting together the data, and this is special projects through the Prevention Research Center. So I know there's already that, and only certain universities can go for it. So we're not going for it until we're eligible. Yeah. Yeah, no, this is really amazing that you're able to do that. One of the few places that you can do that. I want, do you know which other countries have registries like that? the UK or the Netherlands have anything similar?
I think all the Nordic countries have it. So Denmark and Norway, Finland, I think.
I think Denmark as well, to some extent
yeah.
at least.
Yeah. And I don't know. I think there are others, but not maybe as comprehensive as the Nordic countries.
And our
Because,
problem
I mean,
is,
it's also dependent on the personal identification number. That sort of enables everything, that you can link all the registers together.
Exactly.
So
I
it's
think
not
they
just
are.
a matter of having a register; it's that you can link them all.
Exactly. I think there are registers in other countries as well, but they are not able to link them. There are quite strong regulations, I think, to link data sets in that way that we are able to do in Sweden, or allowed to do in Sweden.
Glenn Fugera, who used to be at our university, linked together some national data sets, but it was a huge process. It was really very hard linking the national health interview surveys and survey of employment. And he linked them together over 10 years. It was very complicated, and still the number of people with IDD wasn't that big because they're not the total population. So yeah, it's a challenge. And Medicaid is limiting because it's only people on Medicaid. So a lot of people are not on Medicaid. It'd be mostly disabled or poor.
And we could, I mean, we applied for data in late spring. Was that right, Anna? Yeah, and there is some delay because they have a lot of applications to the National Board of Health and Welfare, and we got a contact person in September, October, something like that. And we are now approved. All the applications are approved, and we're starting to get our data. So when you get a contact person, the process is actually really quick, I would say. I'm a little bit surprised how fast this has gone from the first meeting with the National Board of Health and Welfare in September to this point where we actually get a lot of data.
Yeah.
I'm curious, to what extent are your results being used by the local governments or the federal government?
Well, that's a little bit tricky. As we weren't PIs from that project, we weren't really involved in the dissemination phase, or so it was the PI that was responsible for that. And I know she had meetings with the National Board of Health and Welfare, and she met a lot of municipalities and different institutions to talk about the results.
Okay.
But I don't know if there's been any policy changes and so forth. And I think that one of the goals that I at least have for our new project is to be able to disseminate and implement the results to a great extent. I think, I mean, healthcare research is much about politics and how to provide the results to those that needs the results. So I don't think we could stop just when we have our publication. I think that's when the hard work starts.
Agreed.
Do you agree with that? Have you anything else to say, Anna, or want to cover? Did I forgot anything?
No, I think you made a good point there. We did have, for a brief while, collaboration with PWIDD, the organization for people with intellectual disability and their relatives.
Yeah.
But with everything else during the pandemic, everything just shut down.
Yeah.
And there was also actually the public radio made an hour, I think it was an hour, was it half an hour? A documentary about the study. So it was sort of broadcast nationally on the radio. Yeah. So we have gotten some attention, but if it's gone as far as to the politicians, I don't know.
And I think we had a discussion, I think a few years ago, about the LSS law, how to make that. It's a really expensive law. I mean, it's a tremendous amount of money that are put in that area. And the politicians on a national level wanted to change that because they wanted to use that money for other purposes. And there was a huge debate about not to downsize that service system, which was about to be done, and I think they stopped it eventually. But I don't know if our result had any impact on that, but I don't think so. But that kind of discussion was did we have in Sweden?
I think we have time for one more comment or question.
Can you hear me, Renata? Yes.
Yep.
Yeah, well, I've got a short comment. Thank you, Magnus, and Anna for an interesting presentation. I'm actually based in the Czech Republic. I'm in the United States as a Fulbright scholar. And as we know, in the European Union, we have a number of principles like the freedom of movement between the countries and free access to services, not necessarily free, but equal access to services across the European member states. So I think it would be interesting to do kind of an international comparative study around the medication and intellectual disabilities, also linked to people moving from institutions over last 20 years. So maybe the question is what you consider such a research project in the future to look at other European countries, or maybe also in the United States, to do kind of a international comparison? That's the question also. Thank you.
I think international comparison is a little bit difficult because the service system looks really different. What we provide and what kind of requirements there are to be put in an institution or to get kind of different kind of service. I think it will be suitable to do on hospital utilization, for instance, because we could use diagnosis and such variables that are equal throughout the world. So to some extent, I think that would be really interesting, but perhaps even more challenging than to look within a country. What do you think, Anna?
Yeah, I think I mean the systems are so different. And I mean, as I said, in Sweden, there's like a roof on how much you can pay each year for healthcare and medicine. So you never pay more than, I think, like $200 per year for medicine. If you need more than that, the state pays for it. So I mean, if you were to compare with any other country, you would have to compare with a country that has the same system. Yeah. Because you can't really compare if we get the medicine for free and in another country they would pay for it, and it's the same with healthcare. So I think it would be difficult.
And I think it's the same amount roughly when it comes to healthcare. You just, regardless if you are admitted to hospital for like 3 months, you will never pay more than like $200. Never.
No.
I think you just raised blood pressure of my American colleagues to no end.
And I know, I mean, we're following the news as well. I mean, about the communists and the healthcare system and Obamacare and so forth. I mean, I know the discussions, but I mean, our system is not perfect. But I mean, during the pandemic, there's a lot of people that raising the gratitude for the Swedish system because they realize how expensive the care could be. There are at intensive care unit for months, and they get a bill on like $50 or whatever. I mean, it's ridiculous in some way, but that's the way it is.
Okay, well, thank you so much. Sarah, do you have any concluding comments?
Really, thanks. And Could you turn that off, Jack, for me? Just thank you for coming. And I think there's a lot to think about in regard to what you presented. I think Tamara mentioned there's things going on. I know there's another grant from NADLR trying to look at data. I think, you know, there's some people might be very interested in doing something also around the hospitalization utilization, maybe you mentioned. Certainly there's some ideas too of what we might be able to measure for this specific project. So I really appreciate you coming.
Thank you.
Okay, thank you. And then I
We
will
appreciate
share.
you having us.
Yeah,
I'll share the presentation
Yeah.
if we can. I think that would be nice to have.
absolutely. I will send it to you.
Okay, thank you very much.
Thank you. Have a nice weekend.
And thank you so much.
Bye.
Bye.
Thank you. Take
Bye.
care.